Good afternoon. So we will talk about dysphagia now this afternoon. You know that dysphagia is actually a huge topic, developing very fast over the last few years. It has got its own subspecialties like neurodeglutology, oncodeglutology, pediatric deglutology, neonatal deglutology. So fairly it is a huge topic. What I am trying to tell you here is that how to approach a roadmap to the dysphagia case. So this is a sort of a plan of action, a general plan of action in a dysphagia case. So obviously we cannot go into the details of each and every case because of the time constraint, but I'm trying to give an idea how you should approach a case, what should be the plan of action and how we should be the managing these cases. So just like in any other condition, here we have to diagnose and of course we have to manage. But management may take longer time. The result may come much longer. Sometimes the result may not be complete at all. So in that case, we also have to look into an alternative feeding method because a patient who is not fed well is going to have negative metabolism and there can be a lot of muscle weakness which can adversely affect the swallowing mechanism. Obviously we have to deal with that. So alternative feeding method also is very important in the management of dysphagia. So we are going to look at this problem in these three headings: how to diagnose, what are the alternative feeding methods, and how to manage. We'll first go to the diagnosis. So we have to take the detailed history, obviously. So the aim here is to get the primary pathology diagnosis. I'm not talking about the dysphagia diagnosis, means a laryngopharyngeal incompetence or a cricopharyngeal dysmotility. Not about that. But what is the primary cause? Say like a hemimandibulectomy or a stroke causing the dysphagia. So we have to get the primary pathology diagnosis. Most of the time it is not our work. It will be already written down, documented very well by the primary care physician. So we have to get that. Of course, also from the history, you will get the rough idea about the swallowing pathology. Is he aspirating? Is he getting, he cannot swallow anything, or there is some preference for solids or liquids. So all these things we can actually get. You can see this is a case of a partial glossectomy with a flap there. So that history will be there. So you know what to expect as far as the swallowing is concerned. This patient has got a partial glossectomy and a repair with a small flap or a graft. While this is a case who has got a hypoglossal palsy. You can see that the tongue is paralyzed, deviating to the right side. So that means the patient has got a right hypoglossal palsy following a neurosurgery or a high neck surgery. So again, we know that what is going to be the impact on the swallowing mechanism. So we have got two levels of diagnosis. The primary diagnosis, that's the real disease or the surgery which caused. And the secondary diagnosis, that is a diagnosis about the dysphagia. What is the cause of dysphagia? Or means, what is the factor which is causing dysphagia? Like, is it a laryngeal incompetence? Is it a cricopharyngeal dysmotility? Is it a velopharyngeal incompetence? So on. And in the history, you also have to take the severity of the swallowing dysfunction. So you will get an idea. Patient will say that I can't eat anything, or I can eat only very little, or I can eat normally 80% of the thing, but I have to modify something. And also take that history. You can rule out the history of aspiration as well as history of previous pneumonia. So all these things are going to play important role in the management of these swallowing disorders. So take some time to take detailed history to highlight these points. Now come the diagnosis. So you have to first do the clinical evaluation, sometimes called the bedside evaluation. If the patient cannot be transferred to your room, to your OP room, of course, you have to go to the ward or room and do a bedside evaluation. And with a basic bedside evaluation, including the neurological investigation, the neurological examination, the cranial nerve examination, watching the act of swallowing, auscultating the chest, you can actually safely divide these patients into 3 groups. One, those patients fit for oral feed. You are sure that they are swallowing well, they don't have any aspiration, they can manage, obviously. That's a group 1. Group 2 is the other extreme. They are totally unfit for oral feeds. Either they are not swallowing at all, they are not swallowing, they are spitting out everything, or even if they are swallowing, they have got clear-cut evidence of aspiration, which make that patient potentially a very, very dangerous candidate for oral feed. 3 is the hazy group, the hazy zone group. Maybe there is an aspiration possibility, we cannot be ruled out by clinical examination. They are swallowing all right, reasonably well, but you have got a doubt that patient is also aspirating. So these are the 3 major groups. So what are we going to do with that? The first group obviously doesn't require any further investigation. You can safely start. Then comes the instrumental evaluation. These are for groups 2 and 3. That means where patient cannot swallow at all, or patient has got definite signs of aspiration, or that hazy zone group where you are not very sure, patient is swallowing, but you are not absolutely sure about the safety of the swallow. Patient may be aspirating. So these kind of patients, you have to do instrumental evaluation. And the 2 major instrumental evaluation, of course, is the video fluoroscopy. It's mainly for oral stage dysfunction, esophageal stage dysfunction, and doubtful aspiration on fees. You know that fees has suggested aspiration, but you are not very sure about the severity. Is it mild? You can ignore it or something like it. So these are the cases where you will generally go for fluoroscopy. You can see a few of them. So this is an oral stage dysfunction. You could see the tongue contraction is not very smooth. It is not very coordinated. It's actually very uncoordinated tongue movement. So these things cannot be actually studied by a endoscopic evaluation generally. And this is a aspiration case, which was doubtful on endoscopic evaluation, but fluoroscopy showed, you can see that both anterior and posterior walls of the trachea are getting lined by barium, suggesting that it is fairly a significant aspiration. And of course, you can get esophageal pathologies also can be diagnosed better by fluoroscopy, unless of course you have got a transnasal esophagoscopy. This is a classical achalasia cardia. You can see the megaesophagus and practically total spasm of the achalasia. It's not going down into the stomach at all for most of the time. Then occasionally when the pressure builds up, it opens up. You can even see it is going backward. So these are the things which can be actually diagnosed by the fluoroscopy, or these are the indications for fluoroscopy in these cases. The second most important instrumental evaluation is, of course, the flexible endoscopic evaluation of swallowing. You all know that, fees. And it's predominantly for the pharyngeal dysfunction, where it is superior because it gives the anatomical diagnosis. It gives idea about the saliva aspiration. It gives about the side of the disease. In fluoroscopy, it's not that easy always. Of course, you can take an AP view, but the diagnosis, like a vocal cord palsy, is better seen with the flexible endoscopic evaluation of the swallowing. So here you can see that the right vocal cord is paralyzed. Arytenoid is going anteriorly and medially. There is lot of pooling in both the piriform fossa. You can see both in the right piriform fossa, left piriform fossa, and the post-cricoid region. Patient is trying to swallow, but the whiteout face is there. So that means the laryngeal elevation is good, but you can see some amount of penetration and and of course there is pooling in the vallicula also. No significant aspiration. So these are the things, these are the ideal cases for the flexible endoscopic evaluations. There are a lot of other modalities like transnasal esophagoscopy. You can see that's such a wonderful equipment, especially for the esophageal stage. It's outpatient procedure, no need of any sedation or anesthesia or monitored anesthesia care. You can do that. You have got scintigraphy for detecting the microaspiration. Can get the manometry for the pressure difference system, especially in inferior constrictor dysmotility. And of course, you can have pH metry for reflux disorders and EMG for muscular dysfunction. So again, for inferior constrictor dysmotility, a 2-channel EMG will be very good to differentiate between the thyropharyngeal and the cricopharyngeal dysmotility. Now you have to think about the alternative feeding methods. So they can be enteral or parenteral. Enteral, the 3 major things you know that the most commonly used is the nasogastric tube or the Rice tube. So this is indicated when the requirement is short time, say something around 1 month. If it is more than that, it is preferable to change to the other methods. Of course, in our country, sometimes we prolong it a little longer. PEG is probably the most commonly used technique when the expected morbidity period is more than 1 month. So when long-term feeding is required, you go for the PEG. Most of the time, you can do the percutaneous endoscopic gastrostomy. If that is not possible, it's like some contraindications for PEG, you may have to even do a open gastrostomy. And very rarely, when PEG is not warranted, say like the stomach is not functioning, or patient has got uncontrolled reflux, or you want the stomach for the treatment of the pathology, like you are planning for a gastric pull-up, then you want to avoid stomach. In that case, you go for a feeding jejunostomy. The problem with the feeding jejunostomy is a smaller tube, and you need a GA. And to maintain that feeding with the FJ for a long period is not very easy. And some patient may be totally unfit for enteral feeding, like major intestinal disorder, absorption problem, all these diseases. Then you have to give the parenteral feeding, which may be either the total parenteral nutrition or the partial parenteral nutrition. Of course, it has got its own advantages and disadvantages. A chance of infection that you have to be very careful. You have to maintain the nutritional status very well. It's more expensive. But in some cases, in selected cases, this is invaluable. Now coming to the final part, that is the management of swallowing disorders. So we will divide into 3 groups, even though there is a newer classification of the rehabilitative and compensatory. I will go for the older thing, which is easier to tell. And because the time constraint, I don't want to go into the compensatory and rehabilitative technique. Rather, I will go with the classification of indirect swallowing therapy, direct swallowing therapy, and of course, interventional, means you do surgery or some procedure, which I prefer to call phagosurgery. Indirect swallowing therapy generally means no food is given. What are your aim is that you strengthen the weakened muscles. Some muscles are weakened. So identify which muscle is weakened and select exercises. Again, I cannot go for all the indirect swallowing therapy in such a short time, but there are many. You can strengthen the lips, you can strengthen the palate, you can strengthen the suprahyoid muscles, you can strengthen the tongue muscles, you can strengthen the pharyngeal muscle. The classical button and thread, asking the child to hold a button with the lips outside the teeth is a very good exercise for strengthening the lip. Blowing wind instrument is a very good technique for palatal strengthening, and the neuromuscular stimulation like vital stim is actually very good for stimulating or strengthening the suprahyoid musculature, especially when the laryngeal elevation is not very good. The hyolaryngeal excursion is not very good, and patient has got consequent swallowing problems. So these are the indirect swallowing therapy technique. And the direct swallowing therapy, the difference here is that you are giving food, but some modification is done in the swallowing. It may be different types. For completion, for easy remembrance, I have used this technique, the T's, 5 T's, the time, the temperature, the texture, the tilt, and the technique. We will look into each one of it. So direct swallowing therapy, time means frequency of feeding, how often you feed the patient. Some patient cannot take 3 major meals. Instead, you may have to make it short, small, frequent feed. So that depends upon the condition of the swallowing apparatus and, of course, the general strength of the patient. So you will have to change that. Texture, generally, you can give liquids are good for stenotic conditions, tongue weakness, and pharyngeal weakness. This is a generalization. There may be some exceptions, but generally, those patients who have got some kind of stenosis, tongue weakness, and pharyngeal weakness, a liquid bolus is better. You can see that the patient has got multiple osteophytes, so some narrowing. So this patient is swallowing actually better the liquid rather than the solid. So that osteophytes are causing some amount of stenosis. And same is the case with tongue weakness and pharyngeal weakness. You select liquid. Semi-solids and solids are generally used for laryngeal incompetence. Obviously, you know that if there is a small phonatory, a small glottic gap, patient will aspirate liquid. So, but may not aspirate thicker fluid or semi-solid. And again, for cricopharyngeal achalasia or cricopharyngeal dysmotility, cricopharyngeal spasm, a solid may be better because it gives a lot of mass effect. So these things are important. You can see that this is cricopharyngeal spasm, and you can see that when you are giving thin and thick bolus, you can see the difference. It is opening up very, very, very slowly. Not much is going down, and you can see the difference with each bolus. So with the thin it will be less, but with the thick it will be more. So that is the plan you want to select in cricopharyngeal dysmotility. See, this was a thicker barium, and you could see that the mass was giving more effect to the opening up the cricopharyngeal spasm. So these kind of patients probably solid is better. You can also use temperature very judiciously. You can use very warm things for muscle spasm. Cricopharyngeal spasm is known to relax better with the warm bolus. So you can give bolus. While patient has got a very poor sensation, laryngeal sensation is poor, gag reflex is poor, or habit of keeping the middle cerebral artery stroke patient, keeping the food in the mouth for a long time, you can stimulate with cold. So when the general rule will be, when the sensation is poor, you stimulate with cold. When you are suspecting a muscle spasm, stimulate with warm. Next is the tilt. So tilt the neck in such a way that the gravity allows the bolus to go through the normal side. So this patient has got a right hypoglossal and pharyngeal palsy. So you can see that he is tilting the neck to the left, the normal side. And because of the gravity, food will go through the normal side. If patient is sitting in the normal position, part of the food bolus might have gone through the right side, which is paralyzed, and patient may struggle to swallow. So this is simple thing, but very important. And the final T will be the techniques. You might have heard of a lot of techniques like Mendelssohn swallowing technique, that is elevating the larynx manually, supraglottic and super supraglottic when there is laryngeal incompetence, Massaco's maneuver when there is tongue incoordination, effortful swallow when the pharyngeal constriction is not very good, chin tuck when the cricopharynx is not opening up. All these techniques can be used This is a super supraglottic technique when the laryngeal incompetence is there. What he is doing is that he is doing the bearing down maneuver and also holding breath and then swallow. And at the end of 2 or 3 swallow, whatever little debris is in the mouth, he will spit out to prevent aspiration. So these are the different techniques. Again, a huge topic I can just mention and then finish it off. That is the only way now we can do in this short lecture. That's what he is doing. At the end, whatever remaining in the mouth, he will spit out. Now, intervention or phagosurgery can be a group of surgery like phonosurgery. It's also a spectrum of surgery can be there. Starting from Botox injection for cricopharyngeal spasm, palatopexy for velopharyngeal incompetence, hyoidopexy for incompetent or absent laryngeal elevation, injection laryngoplasty, medialization thyroplasty, and direct no rotation for laryngeal incompetence secondary to unilateral vocal cord paralysis, hypopharyngoplasty for redundant pyriform fossa or thyropharyngeal weakness and resultant pooling and overflow into the larynx from the pyriform fossa. And of course, the cricopharyngeal myotomy or the old operation reinvented, now done more frequently for severe cricopharyngeal spasm. So this is in a nutshell about the surgery, the management of swallowing disorders, which can be approached with a little more confidence if you know the plan of action. Of course, this is a huge topic. You need to develop skill in each and every section I have talked about. And gradually you can see lots of different types of patients, different types of swallowing patient, and can give some help to them. Thank you.